Hi, everybody.
Hi.
You.
Great. How is everybody? Good?
Good.
Very good.
I'm
Well-
so excited for today, and I'm so excited that Beth is looking nice and warm where she is, because I don't know where people are joining us. We may be slightly jealous if you're joining us from a very nice warm spot, meaning you're above freezing as far as we would consider warm right now in Ontario.
Not
Beth,
minus
what's the
27?
Yes, exactly. Beth, what's the temperature up there?
Minus 27. It is no
Celsius.
joke.
Celsius.
It's Celsius, yes. Let's clarify that.
Oh my
Yeah.
gosh.
You're
I'm not
muted
up
again.
there right now.
What does that translate into in Fahrenheit?
Oh,
Get out your
first, just give
calculator.
me a minute.
Beep, boop, beep, boop.
That's what I need him. Okay, Jim, what's the Celsius conversion? He always knows this stuff instantly.
Yeah, so you double it and then you add 32. So that's when you put it to
16. Wait. Oh, I don't know. I'm going to screw it up. Somebody save me from this
Hey,
humiliation.
Hey, Google.
Yeah, there we go.
Yeah. Alexa.
Well,
So-
actually, I do have Alexa on, I should ask.
It's
So
cold.
minus 30 Fahrenheit is, sorry, minus 30 Celsius is minus 22 Fahrenheit.
go.
Still
So
cold.
it's pretty close. Yeah.
So we're not breaking into the positive realm here.
No,
Okay.
Oh
No.
gosh.
no go for that.
It is.
No go for that.
Yeah, you can just
So,
yeah.
how cute the dog is.
yeah.
What's that?
I said you can tell because the dog is very fast.
Yes.
Comes to the
Beth,
door.
you had a funny.
No, I think I'll wait another half an hour.
Yeah.
Yeah. It's like you want to put boots on them and a little coat.
Oh, I
You know?
know. Yeah, it's true. No, my dog was so excited because it's like I say, it's so beautiful and snowy here. So her and I went out for our walk and we're just distracted by the beauty. And then we just at one point kind of looked at each other and just ran home. It was just so cold.
Wow.
Oh my gosh.
Yeah.
Well, I'm excited for today's show. I think we've got a great attendance that are coming. We did get some emails saying people are going to be watching us after, which we know these are always recorded. But yes, I'm so excited to have Dr. Joy here. Kathleen, why don't you start us off today?
Sure. I think Beth, you're going to do your housekeeping.
Yeah. Let's just do just a little bit of housekeeping only because we do have such a big group coming today. So a very fun event booked and scheduled for today. There's usually quite a few questions that come in, and I imagine that'll be the same today. So we're going to try our best to address and answer questions. But if we don't get a chance to answer your question, you will be given, I think Dr. Joy will be sharing her email address. So maybe just jot that down in case there was something that you wanted to ask her and we didn't take it up today. To help us keep questions organized, if you could put any questions into that Q&A for us, then they won't get lost in sort of the chat. If you're just wanting to chat with us, then feel free to use that chat option. We do have closed captioning. If you would like that, you can just hit that CC and those should show up for you. Other than that, I don't think I have anything else to say. So Kathleen, if you could take it away, that would be great.
Thanks, Beth. Thank you. And also I just want to add to that is that we will upload the recording into your portal along with the questions for your certificate. So you can expect that to be done by Monday, okay? All right, so Dr. Joy Void-Holmes is a registered dental hygienist with over 25 years of clinical experience. She holds a Master of Health Science with a concentration in Forensic Investigative Science and Doctor of Health Science degree from Nova Southeastern University. She's the founder of Dr. Joy, RDH, and co-founder of Gel Ed. Dr. Joy has presented a continuing education courses nationally and internationally. She serves as a consultant examiner for the CDCA WREB examining board board member of the Maryland State Board of Dental Examiners, and is on the editorial advisory board for the Inside Dental Hygiene and RDH magazine. Dr. Joy is an active member of the American Academy of Dental Hygiene, American Dental Hygienists Association, and the Maryland Dental Action Coalition. So we are really excited to have you on here with us today, Dr. Joy. And we've been fortunate to be on some of your webinars that we hosted with your instrumentation series with Curion. And we're looking forward to today's topic about diversity in the dental profession, and also with the tools on our tray to help provide high quality evidence-based care. So many people hear the word diversity and they automatically associate the term with ethnicity and race. So can you just explain to us what diversity really means?
I can, and I am going to share my screen here so that you can follow along with me, and you can just let me know if you can everyone see that? We good to go? Okay. Well, since you've introduced me, let's just jump right into it. So again, diversity, a lot of people mistake the term, or they limit it to just race and ethnicity. And this can be a very narrow view. And when that happens, I think that people get a huge misunderstanding of what diversity really is. So very much like culture, diversity are all those things that make us different and unique. So it could be things such as language, your nationality, your sexual orientation, your religion, gender, socioeconomic status, age. It could be your physical, mental abilities or limitations, the degrees that you have, the opinions that you hold, your political beliefs, where you're from, your professional background. And so if you think about, if you just take an example or look at us, just think about how diverse we are. We all come from very different regions of the country. We have, although we're all dental hygienists, I'm sure that we have very diverse backgrounds. Our families are very diverse. And so diversity is a good thing, because when you put all of that together, you have something wonderful that would be like the Dental Hygiene Association, or dental hygienists in general. So sometimes it's unfortunate that people misconstrue diversity with cultural competence. So diversity is where we take and recognize the differences that exist between people. Cultural competence is where we have the ability to interact effectively with different cultures. So I could say, hey, that person's different from me, but that doesn't necessarily mean that I know how to interact with that person. And so as a healthcare professional, while we understand that our patients come from very diverse groups, our team members come from very diverse groups, it doesn't necessarily mean that we know how to interact with those professionally, interact with them professionally. And that is where that cultural competence training comes in. So I like this. This is called the diversity wheel. And if you were to Google diversity wheel, there's various depictions of what it looks like. So the diversity wheel, we have what we call inner layers of diversity and outer layers of diversity. So that inner circle that you see there are things that we're born with that we cannot necessarily change. So our physical or mental abilities. And what I mean by that is that sometimes we're born with mental challenges or physical limitations that we can't change. As much as we want to reverse the clock, we cannot. So our age is something that's constant, no matter how much we lie about it. Gender and sexual orientation, and I know that there are varying opinions on that, but again, we use evidence-based information, and this is what the evidence is saying now, but our race and ethnic heritage. And then if we look at the outer wheel of this diversity wheel, these are all things that do change over time. So whether or not we have military experience, our religion, work experience, education, how we communicate, our income, our family status, work style, and our organizational role. And then if diversity couldn't be more complex, you have what they call surface level diversity. And surface level diversity are those things that you can see about a person. But then you have that deep level diversity. Those are things that you cannot see. And sometimes you have those factors in play. And so what do I mean by that? It would be like someone's attitude. You know, maybe you may see it on my face, but typically when you first meet a person, you don't understand how they may be feeling emotionally, what they may be dealing with, if they have any mental challenges. And so while diversity, simply put, means all the things that make us different, it does get a little bit more complex. So I just wanted to share that with you. So when we use the term diversity, there are typically groups that we associate with that term. And so there could be women, members that associate with the LGBTQIA+ community, individuals with disabilities, and typically we call them the HURE group. And so these are historically underrepresented ethnic populations. So that would be like your African Americans, any of the Aboriginal people, Latin Americans, Native Americans, so forth and so on. And what I have found, especially, I can say specifically in the States here, that diversity has become such a very dirty word. I think it's because of all of the civil and political unrest. I think COVID had a lot to do with it. And so when people say, oh gosh, we're talking about diversity again, I think a lot of times is that just people have diversity fatigue. They're just really tired of hearing about it. And once again, I think it is because they are often associating the word diversity with just race and ethnicity. And if we could start to expand our minds and expand our understanding of what diversity really means, I think that we can come to appreciate that it can be a really beautiful thing. I love quotes. I post quotes a lot. And this is a quote by Brene Brown, and I'm gonna read it. And it says, in order to empathize with someone's experience, you must be willing to believe them as they see it and not how you imagine their experience to be. So what is the lesson in all of this? You need to work towards an improved understanding of diversity. And in order to do that, it is going to require a lot of self-reflection and introspection. So you really need to just take time to sit with yourself and be honest with yourself and say, what is my true understanding of diversity? Do I have any hangups about it? When someone says the word, do I feel a certain way? Am I open to more diverse populations? Am I open to more diverse experiences? So as the old cliche goes, it all starts and ends with you.
Dr. Joy, many of the efforts that we're seeing at actually creating a more diverse culture or more diversity are actually being kind of thwarted by personal biases. Can you expand on that and sort of explain a little bit more about why that's happening or why that exists?
So I started a lot of my work on diversity, I want to say about 4, maybe 5 years ago. And a lot of times you hear things like, oh, you know, they're prejudiced or they're just racist. And, you know, when you stop to think, and I'm like, is it really racism that's going on? Is it really prejudice going on? Or is there something else at play? And what I found is that there was something else at play, and that something else was implicit bias. Our brains receive 11 million pieces of information each second. So I want you to really think about that. 11 million pieces of information each second, but we can only process 40 of those details consciously. So that means 1% of our brain is conscious. So what is happening with the other 99% of our brain? That means our brain is making decisions for us. It's, you know, seeing something and making a calculated decision without us even knowing. And that is called the unconscious bias. You know, when I talk about diversity and bias in person, you know, I love to walk up to people and say, you're biased. And people, they're shocked, they're clutching their pearls. And I'm like, it's okay. We're in the science field. Listen, this is what science is telling us. We are all biased. People who can admit to how biased they are, really, they don't understand how deep the bias runs. And so the way that I like to explain it is that our brains, we have like a systems 1 thinking and a systems 2 thinking. So the systems 1 thinking, that is the unconscious part of our brain. It is deliberate. It makes decisions fast. We don't know what's going on. And this is really, really important because our brains do this to keep us safe, right? So if we're walking down the street and we're uncomfortable with something, our brain is already making a decision for us unconsciously before we make it. So in order to be able to live in this world effectively, in order to be able to live a quality of life, we have to be able to process things really quickly. Whereas your systems too, that's slower, it's more deliberate. It's where your brain has taken time to say, hey, that's a beautiful turquoise RDH View cup. And I like how deep it is, you know, so we took time to process that information. And so understanding, so where does the brain get all of this information from to make these quick decisions without us having to think? And this system's one part of our brain. Well, from our past experiences, our current experiences, the information that we're exposed to on social media, all of the interactions that we have. That is where all of that information comes from. It comes from our upbringing and just anything that we have been exposed to in the past. You know how they say an elephant never forgets, or a woman never forgets anything, especially when she's, you know, throwing it back at her husband. Our brain is storing all of that information so that it can pull from it and make these decisions quickly. Bias is something that I find fascinating. It's called, Harvard has what they call the implicit bias test. I encourage you to take it. It's a free test. It's online. If you Google just the implicit bias test, Harvard University, they test for different types of bias. And so this is another thing that was shocking to me, is that when you think bias, you just think it's one thing. There are so many different types of biases. And with this implicit bias test, it tests to that. So they test your bias on religion. They test your bias on race. They tested on skin color. The one that I took, they tested my bias as it pertains to the role of men and women. And I feel like I'm very progressive, you know, I don't just stay home, I work, I have a career. And after I took that test, I was shocked. And the results of the test essentially said that I have my bias was that I still felt like the woman's place was in the home, and that the man was supposed to go out and be the breadwinner. And I'm like, no. But when I really thought about it, I'm thinking, well, yeah, for my household, I always felt like, you know, no, I want to be home. I want to go to the doctors. I want to see the first tooth fall out. I want to see the first step. And so I am very traditional in that way. So there are other tests where you may come up neutral. So it takes about 5 to 7 minutes for you to take the test, but it's just fascinating. What I will say that the research behind bias is still in its infancy. They are still trying to explain it, but this one test here has stood the test of time. So as you can see here on the screen, there are all different types of bias. So affinity bias is probably the one that's the most common. And that simply means that I'm sorry, let me back up. Affinity bias just simply means you have an affinity towards someone you like the most. So let's just say all viewers here, right? We were in a contest and you're like, Dr. Joy, I need you to pick 5 people to be a part of your master instrumentation class. Pick 5 people that can be your instructors. I don't know any of you because I can't see the participant list, right? So for me, I would say, well, I think I would like to work with someone who is a graduate from Nova Southeastern University. And I definitely want to work with someone who wears hoop earrings and has a bun. And then I want to work with someone who's been to PDC before. And then I want to work with someone who has a degree in forensic investigative science. So basically, I am picking people that I have an affinity towards, that they have something in common with me. So what you're going to find a lot of times in professional organizations, the best example of this is that when you see like the top 100 dentists come out, or, you know, people getting awards and you're like, oh my gosh, it's always the same people. Well, because the people who are picking are going to pick people that are the most like them. So I hope that makes sense. Another one. Go ahead.
I've got small hoop earrings, so I don't know if I count, but I kind of have these on already. But when you're doing that, I'm like, okay, let me put my hair up in a bun. But what you brought up is so important, because we don't realize we have these traits, and it doesn't mean that they're bad. We just have to recognize them, just like we have to understand our biases, like we have to understand our personalities. Like most people in the dental field, I feel like, have been through some sort of personality profile. And the same thing with this bias profile, like just to understand where you're coming from, what your viewpoints are, so then you can better relate to your clients, your patients, the profession at large. Sorry to interrupt, but that's I think that that's pretty fascinating. And I get to be on your team. I get to be on your team.
You get to be on my team. So it's like I say, when you really start to study it, it's fascinating. Another one that it was a perfect example was confirmation bias. And you see a lot of this during political season. So confirmation bias is that you're going to seek out information that is in line with your point of view. And so the example that I read was the one on the gun debate. So let's just say I am pro-gun control and my husband is anti-gun control. So I see like a mass shooting on the news, and I'm going to interpret that as, this is why we need gun control because of all of these mass shootings. And then my husband says, well, no, this is a perfect example as to why we don't need gun control, because everybody needs to be armed to protect themselves. So, or let's just say, Democratic and Republican, I grew up in a very interesting household. One parent was a Democrat, one parent was a Republican. So of course, my Republican parent is always going to watch news that has a Republican point of view, and the other parent who's a Democrat is going to watch news that supports a Democratic point of view. And what's the danger in that? The danger in that is that you never are able to see things from another perspective. And so sometimes your views can become skewed. Ageism. I didn't even think that that was a type of bias. And to me, that is running rampant in our profession. Nobody's talking about it. And what do I mean by ageism? I've been practicing dental hygiene for the past 50 years, and there's no way that this new graduate who just graduated 6 months ago can come into this office and tell me anything new. Think about it. It happens all the time. Or you have the new girl who comes in and says, you've been practicing 50 years. Your way is old and antiquated, and there's no way that you can teach me anything. So we see that a lot in the profession, and we also see it a lot, just in the world in general. So guys, take the bias test. Bias, it can be overcome, but you have to really, really, really work hard. And as Carrie said, sometimes you have to know yourself, and you have to understand that, oh, I'm thinking this way, this could be a bias. And when you can start to recognize it, you can start to work to retrain your brain and retrain the way that you think. But guess what? It is not going to happen overnight. It won't happen overnight. And if somebody calls you biased, doesn't mean you're a bad person. Just say, yes, I am biased, recognize what your biases are, and, work to change them.
So do you have any steps you can help us? Because I feel like with all you've uncovered, oh, perfect. You're going to talk about that next. Excellent. So if you can help us give some of the viewers some easy takeaways, some easy steps that they can go, because I think identifying bias, identifying diversity is so important in the field, because it's bigger than just race, as you said. And I feel like that's where it gets pinholed. There's so much more to it. And then we can better our client care, better our clients' expectations. We can better our communication with the people we work with, and have a better understanding. So yes, please answer my question. I'm excited.
No problem. So the first thing I would say is you have to just take more than one diversity course, and you have to take more than just one cultural competency course. So in my research, you may say, okay, we've been taking diversity training and cultural competency training, and nothing is changing. Why is that? Well, the research is starting to find flaws in that. The biggest flaw, and I'm like, wow, that makes sense, is that a lot of diversity training is geared towards the white male interacting with other races. And the last time I checked, we don't have any males on this panel. So if diversity training is just geared towards a white male interacting with other people, then how is it teaching me how to deal with you, and vice versa? So what we have to understand is that, yes, it's important to understand diversity. And yes, cultural competence training is important, but we even have to go beyond that. We have to get training in inclusion, right? We have to get training on what it means to be practice cultural humility. So it's not just about learning how to work with me. It's also about understanding my experiences. And so again, the training never stops. Diversity is so fluid. Like culture is fluid and it's constantly changing. So as things change, like in our profession, we are mandated to take continuing education all the time. Because diversity is so fluid, you need to continually train yourself, check your bias. Again, once you introspection, right? Self-reflection, understanding what your biases are, doing the implicit bias test is another. These are things that, guys, you can do from the comforts of your own home. Another thing is you have to be comfortable with having very, very uncomfortable conversations surrounding diversity. I think a lot of times people like to walk on eggshells, and we have a saying, you need to call a spade, right? Sometimes you just have to be okay with asking the difficult questions. You have to be okay from hearing another person's perspective, understanding another person's way of life. One way that you can do that, I think, is that we have to be able to create safe spaces. So I always say in my diversity course, if there is a question that you have, as long as you are authentic and respectful, I want you to ask it. I think a lot of times we hold back with asking questions, and when we don't ask the questions, we become ignorant to what it is that we need to know. Monitor your media. Whew, that's a big one. I will tell you, after this last election season in the States, I had to turn the media off, and I developed such a more positive outlook on life. I think the media is wonderful for so many things. It gives us a global view. I could have a best friend in Nepal if I wanted to, because of social media and Zoom, but it also, to me, can be very dangerous. We found that they have these algorithms, and they, specifically push content towards your page. And then when you constantly expose yourself to negativity, or you're constantly exposing yourself to a certain message, or to just a certain point of view, sometimes you lose perspective on other ways that things can be done. And then you want to make inclusion efforts a must. So there's a saying, don't just invite me to the dance, you need to ask me to dance. I like to say, during the holiday season, there's always that one family member that maybe your mother or your father tells you have to invite. You have to invite your aunt. You can't just not invite your aunt. I know that her kids may be bad, but you have to invite your aunt, and you invite your aunt, but then nobody talks to her. So yeah, that's diversity without inclusion. So it's like diversity is the mix. So for those of you who bake, diversity would be, you have the eggs, you have the butter, you have the flour, right? That's diversity. Inclusion is when you mix all of those things together and you get this nice, beautiful cake. So those would be some steps that you could take that, you could do from the comforts of your own home.
That's really fascinating. And it makes me think of how we also interact with some of our team members, because we may feel like we are inclusion and including everybody because we're sitting there, but we maybe invited them, but we're not actually communicating with them. So it's that, like, I'm going to throw you the bone, but I'm not actually going to have that formal conversation. And I think when I think about this too, I think of that initial slide you showed with the exercise 1 and the exercise 2. The more you expose your brain to, the more your brain's going to respond without even thinking that way. And that's where understanding your bias, understanding what you expose yourself to, really does play in some of these decisions that we don't even realize are being made. And so I think that that's a huge thing. And here, at least in our family, just like you with the news, we stopped watching it a long time ago, especially when COVID hit, because my kids would come in and they were terrified about everything. And it's good to know what's going on, but how much of that do you need to expose yourself to in order to understand how it's also affecting other parts of your life? That's all it's about. It's about how you can manage and mitigate some of that information.
Absolutely. And what I will say with inclusion, okay, you've invited me to the dance, you've asked me to the dance, but I still don't feel like I belong. And so you will find that in a lot of trainings, they say diversity, inclusion, and belonging. So yes, you've invited me, you said, hey, come sit at my table, but then I still feel like the outsider. So belonging, so again, it just doesn't start with diversity. And I think that this is where some of the trainings, they just fail to encompass all of that. And it's a lot. It's not something you're going to get in an hour or 2 hours or even half day. Your journey to understanding all of this is just, it's ongoing. And so I think it's just important to know that.
So
And I
Dr.
love too that you just mentioned the embracing of the discomfort, because I think that that's, I know a lot of us are at the point where we have really started to recognize where we have bias, but then there's that fear of, what if I ask a question and it's taken the wrong way, or I say something just stupid because I just don't know any better. So I love that you just kind of alluded to just embracing that discomfort. And as long as it's coming from this genuine place, it's better to ask the question than to just sort of remain ignorant, for lack of a better term. So thank you for addressing that. That one hit home for sure.
No problem. What I say is that you have to have, I said, create a safe space where you have to have like safe relationships. So Emily Bogey, many of you may know her. She is a farmer from Iowa. She's a white woman from Iowa. I'm a Black woman from DC. So we grew up very differently. And so when we have questions, we understand that we have created this safe space where we can call one another and ask those questions. And so I encourage you to find people that make you feel safe, that say, this is a safe space for you. I want you to be able to ask your question. And then, we are able to educate one another. And that's just been a beautiful thing. It really has been.
Before we
beautiful.
move on, can I ask a question? How do you help someone feel like they belong? Because it seems like sometimes we try, but do you have any little tricks, or you can think about it, or, offer some support? But I feel like a lot of us try to make people feel belong, but maybe we don't actually feel like maybe there's some steps we can go further for that.
Well, asking the person how you can make them feel like they belong.
Okay.
I hate to keep using professional associations, but we're all professionals here. As you know, at one point, the association just had a certain type of demographic, right? And then eventually it expanded, where you started to see more people, more men, more people of color, people of different religions and sexual orientations. Okay, so we're there. But then you also have to have classes and activities that speak to them as well, right? So I like to say I have a very eclectic style, but if I walk into a room and you're playing like a 1920s Mozart, not to say that I can't appreciate it, but I don't know if I'm gonna stick around for hors d'oeuvres if that's what you're playing all night long. I don't know that I feel like I belong. And I know that's a very general thing, but sometimes you have to make sure that you have things and activities and policies in place that make that person feel like they belong. So sometimes just asking, say, so you guys at RDH View, we want to host this in-person workshop, right? We're going to do a hands-on workshop, and we want everyone to feel like they belong. So maybe putting out a survey to ask, potential participants certain questions, so that you make sure that you're catering to that demographic.
So, Dr. Joy, how does diversity translate to what's on your tray and your hygiene armamentarium? I get the point, like there are points in the day when you come across that you're meeting with a certain client and you have that uncomfortable sense that you can just feel in the air. And of course, that makes it challenging to treat them. And you kind of recognize, you have assessed yourself that you're not feeling on your game at that moment, and you identify some gap. So how can we recognize that in ourselves, in our day-to-day treatment of our clients? And then what makes the difference for what we're choosing to work with?
Absolutely. So it would be, if you think about dentistry as a whole, right? And if we look at the different specialties in dentistry, people have an array of problems. There's a reason why we have an orthodontist. There's a reason why we have a prosthodontist. There's a reason why we have a periodontist. There's a reason why we have pediatric dentists, because there's some people who should never work with kids. It doesn't make them bad people. They just simply don't have the temperament, right? There's a reason why we have orthodontists. And so that means that, with the various specialties that we have, we're able to help patients with a variety of problems and we have experts that can specialize in that. And so it's the same thing with what you have available in your operatory and what you have on your tray. Our patients do not walk in with a one size fit all approach. I love it when I hear hygienists say, oh, I can clean the entire mouth with one instrument. That is not a badge of honor to me, especially when you think about the new AAP staging and grading guidelines. You have, I love this category. So you have this patient with pristine health on an intact periodontia, right? But then you also have a patient with pristine health on a reduced periodontium. And let's just say certain areas are 6 or 7 millimeters, right? You mean to tell me that you can use the same thing on those patients, or the same thing that you use on a patient with pristine health, you can use on a patient that's like a stage 3, grade 3? And there are some people who practice that way. It's a one size fit all approach. Those two patients have very, very different needs. And so you have to have a diverse armamentarium at your disposal to be able to offer the best patient care. So this is just a great picture. Just look at the periodontium. I want you to look at the tissue. How is it that you're able to take in the one instrument that everybody loves to use? I can treat, everybody with one instrument, is the sickle. How in the world are you effectively debriding this advanced perio condition, especially if it were a molar, with an anterior sickle? It just, I don't want to say behooves me, but it is just shocking to me that we have people out there that practice that way. This was a great picture. So this is an area, it's called the periodontal inflamed surface area. So to make this easy to understand, inside of the periodontal pocket, we are able to measure the amount of infection. Okay, it's called the PISA area, right? And so someone with gingival health, right? That would be, or just a slight tiny bit of gingivitis, that would be the equivalent of a paper cut. If you have a paper cut, are you going to continuously let it bleed, or are you going to do something about it? Now, someone with periodontal stage 3, which is grade BC localized distribution, that equivalent is what you see here on this picture. Would someone walk around with this infected, I don't even know, it looks like an ulcer. Would someone walk around with that, or would they do something to treat it? And are you going to treat this ulcerated lesion the same as you would treat a paper cut? And the answer is no, but we're doing that in dental hygiene. We're doing it in dentistry, right? And so in order to be able to effectively treat a paper cut and effectively treat this lesion, or this ulcerated lesion, we have to have different tools at our disposal. The prognosis is going to be different. The cause was certainly different, right? The way we go about treating it is going to be different. And we really need to start approaching our periodontal care the same way. So if you were
the exact statement you made with regards to a paper cut versus like a bed sore or what have you is such a great visual explanation to a patient, and say, hey, this is how you present, regardless of the stage and grade, if that gets all confused and they don't understand. This is a really great takeaway to say, hey, this is why we need to do X, Y, and Z. And this is, how we need to go forward. But that in itself was, I loved how you mentioned that. So that I took that away. Thank you.
Yeah, and patients understand pictures, right? They understand pictures. So we can say, yes, this is the equivalent of what's going on in your mouth right now. Now, who would want to lay next to you? Who would want to kiss you, right? That's someone that you probably wouldn't want to deal with. But again, we know that if someone is bleeding from somewhere constantly, they're going to go to the doctors, and they're not going to question what the doctor wants to do, their medical doctor. Why is it that they have to constantly question us? So no, I think pictures, and I'm sorry for anyone who's eating, and if this grosses you out, I probably should have given you a disclaimer. My apologies.
One of the things we say in our office is, are you kissable with bleeding gums? And that makes people go, whoa, no, but it is the truth. We've become so common, and it's so normalized in our world that they come in, they're going to have bleeding gums. Well, that's not the case. That doesn't have to be the situation. We have to change our bias and our understanding to get them into a healthier state. So anyways, I will stop talking. I will let you continue because you've got lots of great stuff to share with us.
No, it's okay, and I completely understand. I remember very early on, I think I was 21, practicing in downtown DC, and I had a lady come into the office, and I mean, it was really like severe periodontal disease, where we didn't even think that she would be able to keep any of her teeth. And the question that I had is, well, what made you come in now, given everything that I saw in her mouth? Oh, I woke up and there was blood on my pillow. How bad do you think that periodontal disease had to be before blood is on your pillow? I want you to, so it's like, my gosh, who failed you along the way? So the more that, you know, it's in that same office where I heard a young lady, she's like, I love telling patients they have an infection. It was like, ooh, I can't wait to tell someone they have an infection. But saying that your gums are bleeding versus you have an infection has it just hits different. So yeah, we can't be afraid to tell our patients that. So what would I have in my office in a perfect world? What would I have on my tray? Well, here's just a few things. The first thing I would have is an intraoral scanner. Your intraoral scanner, guys, is like your new mouth mirror. I think that is going to be standard, not just in the office, but in all hygiene departments. What I love about an intraoral scan is that a patient can understand a scan. How many patients can legitimately read and understand x-rays? They can't. But when they see their actual mouth up there, they can understand a picture. And so when they're able to understand the picture, I think it enhances your oral health education sessions. It's going to improve your relationship. I think they're going to develop a better trust. When they trust you, they go along with treatment, and that helps to improve patient outcomes. You can make recommendations that are easier to understand. It's going to save you time. Just think that X-ray is not going to show you erosion. An X-ray is not going to show you recession or wear patterns. These are things that your intraoral scanner will do. And then you're able to diagnose things in your operatory that the dentist then gets to treat and charge for. And so now you've become a more profitable hygienist from that standpoint. Lasers. I would absolutely have a laser. We know that a laser can be beneficial for so many different things, treating those herpetic lesions for the LPR and the LAPDT, desensitization. So how many times have you had a patient come into your room and you go to probe and they jump out the chair? And what do? You just don't probe that tooth, and then they don't brush that tooth. But why would something like a laser to help desensitize that area so that you can provide treatment? Did somebody have a question? Well, okay, I thought I heard something. Lasers are wonderful for treating and maintaining implants. So implants aren't teeth. So we need to start treating them like they're teeth, and using that god-awful plastic instrument that really does nothing, and start using different tools in our armamentarium that we have at our disposal. I would absolutely have an air polisher. I haven't even gotten to hand instruments yet, right? The more that we start to understand about the oral systemic connection, the more that we understand that it is the presence of the biofilm and the host response to that biofilm, the more we will understand that we need things outside of an ultrasonic and outside of a hand instrument, right? Our ultimate goal should not be to see how smooth we can get the root. We're way past that. Our goal is to really eliminate that biofilm, thereby eliminating that inflammation. And we want to do that throughout the lifespan of the patient. That is our goal. So there's a lot of research that speaks to the benefits of subgingival air polishing. So I would certainly have that on my tray and in my operatory. Fluoride. I think that this is, from a dental hygienist standpoint, liquid fluoride varnish and silver diamine fluoride is so highly underutilized. Again, you have so many, one in every 3 patients is suffering from dental hypersensitivity. And I've studied this quite a bit. What I didn't realize is how it affects quality of life. There is some research that suggests that people's teeth are so sensitive that they become depressed behind it. They don't eat, they don't go out, it affects their oral hygiene. And so why wouldn't we want to be able to treat them, provide them with options? We know that caries is a worldwide problem. So not only are you maybe potentially helping a patient that has a sensitive tooth, but you're also helping them maybe prevent caries as well. There's research in its infancy on the benefits of silver diamine fluoride in preventing caries and inhibiting biofilm. There's just not enough for them to make a label claim, but there are some research articles out there about that. The liquid varnish, I suffered from sensitivity. I will admit I was the crazy person that did the apple cider vinegar diet to lose 20 pounds, right? I did the lemon and the turmeric and all of that. And just everything that we eat has sugar and acid in it. So our teeth are constantly under attack. So people are suffering from sensitivity. And so this liquid varnish to me works wonders. It works it just works well. Of course, ultrasonics is standard of care. I know during COVID, they were like, oh my gosh, nothing that generates an aerosol. But I don't recall dentists ever putting down their high-speed handpieces. Some did, some didn't. But ultrasonics is still standard of care. We know that it has so many different benefits. So of course, I would have ultrasonics on my tray. Now, here's my gripe with ultrasonics. Again, it's not a one-size-fits-all approach, right? You should not just have one ultrasonic tip in your office. Your patient is going to drive your selection. So for those of you who, I guess, live in areas where you like to do, I don't know what you call it, when you like to drive off-road with these big trucks and Jeeps in the mountains, I'm not sure what you call it, right? But there's a certain type of vehicle for that. It's usually a truck with these big monster wheels. But for those of you with a little tiny convertible, you would not drive that through the mud, right? So your conditions will dictate the type of car you drive, just like your patient will drive your tip selection. So understanding with ultrasonics, this is just one company because I had good pictures, right? They have different size tips to address the different patient conditions that you have. So I'm using Dentsply as an example. They have a power line. It's meant to be used super gingival on high power, right? I will admit I was the hygienist that had high power for everybody and one tip for everybody because I had not received any formal training on ultrasonics until much later in my career, right? But there's just a tip for that, right? And you shouldn't be using all tips on all modes of power. I'm just going to throw that out there. Then they have what's called the slimline. That's for moderate to light deposits. You will see that the tip is thinner. So, when you have those tight pockets or you're going subgingivally, you don't want to distend the tissue with that big, bulky, thick tip. So you have these slimmer tips. So these tips are 30% slimmer than their standard tip. And then you also have the right and left tips. And then you have thin certs. So almost all companies have what they call an ultra thin ultrasonic tip. This thin cert here from Dentsply is as thin as your 1112 Explorer. So I'm gonna let that sink in for you for a minute. This is just a picture to show you the benefits of using a right and left tip. I do these courses all the time when people say, I don't need to use a right and left tip because I'm able to adapt my straight tip on the root surface. Well, how do you know? Can you see? Are you flapping? If you're flapping, you probably could. But if you're not flapping, just the very nature of the tooth anatomy, you're not able to adapt a straight tip. I think with right and left tips, people are intimidated because they don't know how to use them. But this is one good thing about social media, guys. I would tell you use YouTube because it tells you everything about a right and left tip, even if you forget it chair side. Okay. Let's see, what else do I have? Hand instruments. I'm often asked, what's the best hand instrument? What would you recommend? And I'm always going to say, I recommend the one that feels the best in your hand. Now, there are certain design characteristics that you need to consider, specifically the handle design. So you definitely want to look for a handle that's lighter. You want to look for a handle that's wider. So my instruments were all stainless steel. They were heavy and very skinny. And we know that that contributed to a lot of the repetitive stress injuries and carpal tunnel injuries, those musculoskeletal disorders that we often suffer from. So ideally, you want an instrument that's less than 15 grams. You have some instruments on the market that are as wide as 11 millimeters. So the width of your instrument really matters. So that's why a lot of the companies are making wider instrument handles. And then of course you want something that has texturing and knurling on it. So almost every instrument you pick up, you're going to feel some sort of pattern on it. And that's number one, you're not going to grip the instrument as hard, and it helps you to maintain control in a wet environment. So all companies make good instruments. I have so many diverse instruments because there are some designs that not all companies will carry. So everybody knows Hugh Freedy. They are the leading supplier here in North America. As you can see, they recently changed their handle design. And all companies have their version of staying sharper longer. So for Hugh Freedy, it's Ever Edge. And what does that really mean, right? It just means that all companies have really, they're studying metallurgy and they're using cryogenic processing so that you have some really advanced metals that are staying sharper longer. And then you have some brands that make instruments that you don't have to sharpen at all. Nordent, that's another stainless steel instrument. They have what's called the True Gracie. So if some of you have been practicing long enough, you may remember the original Gracie design by Dr. Clayton Gracie. Those Gracies had more of a curvature, and a lot of the Gracies don't have that anymore, but Nordent went back to that original design. And the benefit to that is that the tip or the toe of the instrument hugs the tooth, so you're not sleeping out on the other side. You're not causing that damage. They also have a free sharpening program. So love their instruments. You then have American Eagle. They have a resin handle. So they make stainless steel instruments, and then they also make their XP. Their XP instruments are coated with a titanium coating. So these are the instruments that you don't have to sharpen. You have PDT. PDT is another resin-based handle. This is like one of the lighter instruments on the market. So these instruments were designed with ergonomics in mind. You have Premier instruments. So they have 3 different handle designs. So I have them pictured here. And I have all of these, by the way. I collect instruments like some people collect stamps for shoes. Call it an addiction. And then some of my favorite instruments are these LM instruments. I fell in love with LM first because of this Flex Explorer. It is the thinnest Explorer, in my opinion, on the market. I have taken this instrument and asked other companies to thin their Explorer out like this. And at the time they could not. I'm not saying nothing, things haven't changed. LM also makes instruments that are coated, meaning that they, have a, LM calls it sharp diamond. So it's a physical vapor deposition that they use to coat the end, so you don't have to sharpen this instrument. And then they also have an uncoated stainless steel. What I love about LM instruments is that they have a silicone handle. Oh my gosh, absolutely love it. And again, you can feel the difference. I'm not being corny. That is their tagline. But if you put that instrument in your hand, you absolutely would feel the difference. What I will say for your hand instruments and your ultrasonic tips, they don't last forever, guys. If you're using an instrument from 2015, you really need to go have a conversation with your employer or have a conversation. So for those of you who may have done some ortho work, your periodontal instruments aren't going to last as long as those ortho pliers. And there are a number of things that contribute to the lifespan of an instrument. What type of deposit are you using it on? How often are you using the instrument? Do you use ultrasonics beforehand? Are you using that instrument to open boxes in your office, which you should not be doing? For your ultrasonic tips, using a worn out tip will increase your scaling time, and it will increase your scaling force, meaning you're going to press down harder and your patients aren't going to like you very much for that. So those are all the things that I would have on my tray and I would have on my office. And again, based on the AAP staging grading guidelines, what we know about oral systemic connections, you have to have a multitude of things to be able to treat the various patients that you have coming into your office.
I'm glad that you showed us so many different options, because I feel like, everybody needs to be treated, with a unique situation. And I love that you showed us sort of the lifespan of an instrument, because sometimes this is what we forget. And being the beginning of the year, it's a great time to go to your boss or go to your ordering people and say, hey, I want to present a case. I need to update this. Can I put some of this in this quarter? Can I put some of it in the next quarter? How can we budget it through? Usually you're not going to get drop shipped 3 new Cavitron tips and 25 new scalers in one visit. That's usually not been my experience. However, when I say this is my wish list and this is what I really need and this is what I would really like as we go through, it'll help to provide it. And, you know, showing them also looking at your probes, if you're using any color probe and your coloring is gone, show that as your evidence. Hey guys, like the color strip is gone. I can't be as effective. It's not going to help. And I need this to help diagnose, to help provide and educate the patient on the treatment they require. But this is such a big thing. And definitely we need diversity within our office and definitely on our tray. Beth, I know you would have been excited when you saw the laser up there too, because I know you have, you know, and I and many of us have had great experiences with that, but that definitely was nice to see that. I could see the smile, the sparkle in your eye. You're like, yeah.
Yeah,
So Dr.
a lot of my
Joy,
emotions right here.
so Dr. Joy, what types of instruments do you use? Like you say you have a whole variety, and what are the styles? Like, do you use the Synthet? Do you use a universal scaler?
Yeah, so I get it. I will say, let me back up a little bit because I want to address your question in something that Carrie said. I think for me, very early on, I was the hygienist that said, oh my gosh, I don't need ultrasonics. I'm going to prove to the world that I'm the best scaler, right? And so I started to experience problems with my hands very early. I had an instructor who said, you know, you want to be careful of using instruments that are retip. Your instruments are your instruments, and you need that's going to translate into how well you treat your patients and how long you're going to last. And so very early on, I noticed that I was using ineffective instruments. In 21, 22, I gathered all my research articles, gathered the instruments, and I went and had a conversation with my employer. Like it was a complete presentation, guys. Like I had to sell myself. And from that conversation, I got 8 brand new standard setups, 3 perio setups, and I got the same for all of the other hygienists in the office. So it starts with a conversation. You know, like Carrie said, it's not like you can go and say, I want 25 things. You have to present a case for yourself, be comfortable having the conversation. And then sometimes you have to ask for a budget, right? So if you give me a budget and tell me how often I can use this money, I'll be able to figure out how to mix and match. So with that being said, what do I like to use? I absolutely love LM instruments. So my favorite instrument in the world is an Explorer. As hygienists, I think we don't use it enough. And that's why we wind up overscaling. Like if there's no deposit, if there's no calculus on the tooth, why are you picking up a hand instrument?
I just saw a post on Facebook. One of the, I think it was like just the regular North American, it wasn't American or just Canadians, but it was asking who actually uses the Explorer 1112. And I couldn't believe when so many people said they don't use it, that they just use scalers and floss. And I was just like, oh my goodness. I just can't imagine. Yeah.
Yeah, it doesn't make you any less of a hygienist because it's Explorer. I don't get it. So
before, during, and after. Yeah.
Before, during, and after. Absolutely love the Synthet. For some people, they know it as the double Gracie. And so, you know, I'm a big believer in that you don't need 15 instruments on your tray. And this is the beautiful thing about innovation and technology. These companies are using their brains, and they're taking the design features of a universal and area specific and making one instrument. So your double Gracie or your Synthet is like your 1112 and your 1314 in one instrument, right? So you're able to be more effective. That's less reaching. So that's better for you ergonomically. It's more cost effective. So if you could take 2 instruments out of every kit, you might be able to create another kit. So I absolutely love those. I love minis. Absolutely love minis. I think that they are highly underused. There is an instrument by Nordent. It has a hoe on one end and a spoon on the other. So for patients where ultrasonics may be contraindicated and you have that calculus bridge, oh my gosh, it works wonders. Any good hygienist should have a sickle. So I have a slide that I use and I'll call them the jacks. So you have your black jack, your Montana jack, you have your smart jack, and then I throw the Nevi in there. Those are all scalers. So I love me a good Barnhart. I like the USC one too, which is exclusive to Hugh Freedy. So, you know, all hygienists I think should have a periodontal file for roughening up that burnish calculus. I'm big into having a functional ultrasonic unit in multiple tips, but I mean, you give me anything. I love my Sub-Zeros. Those work really, really well. What's another one that I've kind of fallen in love with?
What about implants? Like, what about implant scalers? I know you briefly mentioned that, and I can see the chat kind of blow up a little bit about implants. Any specific or any ideas to help that conversation with their doctors as to why they need to have more than just the plastic scaler?
Well, first of all, there's been some research about that plastic and that residue, and what are you really removing with that? So in terms
Yeah.
of implants, a lot of the ultrasonic manufacturers have designed tips specific for implants. So, gosh, I wish that when I wish I had that when I practiced full time. But a lot of the companies, LM being one of them, so I think Curion does the distribution for that. They have a line of titanium instruments specifically for implants, and it's more than just one design. So you actually get a universal, you get your area specifics, you have anteriors, and then PDT, they actually have an implant kit that you can use that is really specific for implant maintenance. So if you are in a practice and you are seeing a lot of patients with implants, you need to consider that. And then of course, the air polisher and the laser, again, your implants are not teeth. So you have to have the armamentarium at your disposal to be able to treat those patients effectively.
And what is your favorite probe?
My favorite probe is the UNC probe. It goes all the way up to 15. I don't
Yeah.
have, I can count.
Yeah,
Yes, that's my favorite.
very good.
Let me see. Beth, have there been any other questions that have come in? I know there's been a lot of things. I've been trying to look at them. I think you have as well. Is there anything else here that we can fit into today's show?
Guess just
You're muted.
there was one just about,
No, you're good now.
I am?
Yeah,
Okay.
you're good.
I'm like, there was one question just about the difference in technology versus like a piezo magnetic-strictive, and if you wanted to touch on,
Sure,
maybe
absolutely.
that's a big question.
No, it's okay. So of course, you know, they're two different technologies. With your magnetostrictive, that's more of an elliptical motion. And so you're going to be able to use all sides of the tip. With the piezo, it's a linear motion. So only the sides of the tip. What works best, right? If you look at the research, you're going to have people that are in favor of both and people that don't like both. So for me, I feel like you should use whatever you can work the best with. And so for some people, it is the piezo. For some people, it is the magnetostrictive. But they all have benefits to them. Again, it does replace a lot of the work that your hand instruments can do. So again, I can't say that, oh, you should use the piezo or, oh, you should use the magnetostrictive, because if you know what you're doing, just like I know how to floss, right? There are plenty of people that were flossing long before water flossers came out that had really good hygiene. So although we know that a water pick or a water floss, excuse me, could be superior, doesn't mean that someone who chooses not to use one is going to have poor hygiene. So I just say you definitely have to use what works the best in your hand.
And I think too, I know Annalise, you've got so much knowledge on the piezo, but I think too, we have to know what we've got access to. Sometimes we're limited to what we have in our offertory, and making sure you understand how to use that technology and how to best apply it to your clients that way. But if you have that wish list and you're able to do your research, see what works best for you, try and pick up those scalers when you get an opportunity to go to live events. And Anna Louise, I think you were saying that like the live event stuff is almost down by 50%, right?
Yes, we've all been out presenting, and a lot of the live events, the attendance is down 50% or more. And so I'm going to encourage everyone to step out. They're taking lots of precautions. There's lots more space than we traditionally have had at live events. And we're all going to be out there over the next couple of months. And as a result, we're going to miss the next 2 months on the view here because we're all out there presenting. But, if you haven't been out yet, take that step. It will get easier, I promise you. But all the organization committees are very aware of the apprehension and the concern. And, we're all in dentistry. I mean, when you go to the bathroom, we used to all stand there and brush our teeth, and no one's doing that anymore. But there are people stepping outside and doing dry brushes in front of the flowers, in New Orleans. So don't worry, step out and come and join us in person, because we all need that support of being with each other.
Yeah, I agree. I want to say thank you, Dr. Joy. I really appreciate you taking the time to join us today. I know this has been a really great session. There's been some amazing comments. They love your slides. They love the knowledge. And I think you brought such an important message that we may have to kind of schedule you back next year to talk more about this and kind of give us like part 2, because I think you really unpacked so much in this conversation. Because when we started talking, you were like, okay, wait, we need to talk about all of this stuff. But I really feel like if you can get out and you can attend some of these sessions, you can try the tools, think about some of the diversity and where your biases are. And I know RDHU is going to send in one of the quizzes that you mentioned. We're going to kind of send it in one of the follow-ups, so you can have that opportunity to do that bias and think about it from your clinical side. Think of it from your personal side. You may have a slightly different bias depending on which hat you're wearing. But I do want to say thank you, Anna Louise. You're right. We're pausing the RDH for 2 months only because we are on the road a little bit with lots of seminars, lots of things. So our next show will be in April. Sorry, not in April. I apologize. We said that again. In May, we're going to have Amanda in, who's the deaf hygienist. And so she's going to be talking to us about how we can help the deaf community, what we should be knowing, how we can better serve those that area. And Kath, what do we have going on at RDHU this next month?
So this next month, we have for all of our live streaming courses, when you register yourself, you can register a friend for free. So whether we can send them a gift card, and we have a plan on how nice it'll look for the email, and say, so-and-so has registered you for these courses, or you can simply split the course with them, right? But we're all about, February is Valentine's month, Galentine's month. It's about love, and what better way to spend that month than learning with your bestie and with your colleagues. So we've got Mysteries of Myofunctional Therapy with Joe Siegfried. We have Easy Steps to AAP Classifications with Carrie, The Challenges of Implant Care with Anna Louise, and then Influencing Oral and Systemic Health, a 4-stage approach with Lorraine Gambacor. So we've got a great lineup of courses coming. So when you do register for one of those courses, just email us who you'd like to send the gift registration to, and we'll take care of that.
Awesome. Thank you so much, everybody. Dr. Joy, it's been our pleasure to have you on our show.
Thank you, Dr.
Thank you
Joy.
very much for joining us.
Thank you. It's been a pleasure. I hope that you guys found this information helpful and meaningful. And I hope to see some of you at PDC. I will be in Canada.
We'll see you. We'll see you there.
Absolutely. Thank you.
Thank you, everybody. Have a great afternoon. Have a great weekend. Bye.
Bye. Thank you.